And get started. Um, Welcome. I'm Jennifer Loudon. I think I've met many of you, but probably not all of you. I am the facilitator this year for the McCormick Health and Wellness Network. And one of the issues that our network indicated they really wanted to work on was determining if becoming Medicaid managed care eligible was the right move for their organizations. Many of you joined us a few weeks ago when we sort of did an overview of what does it mean to become Medicaid eligible and what are all the systems that are involved. And this is a follow-up presentation where we're doing a deep dive into one organization's sort of process by which they did become Medicaid eligible. And I cannot thank One Hope United enough for being willing to work with our presenters today to put together this case study so that we all have an opportunity to learn from the process they went through. I'm going to encourage you to open your chat so that we can drop questions in there along the way, and probably share some resources and links there as well. So we are planning to be here for 90 minutes today so that we can really dig in on the process and all of the exciting lessons that I'm sure One Hope United learned along the way. And then we want to make sure to really get your questions at least on the table, if not answered today. So I'm really looking forward to this presentation. I have to step out in the middle for a little bit, but I will be here at the beginning and the end. And it's a real great learning opportunity. There are no poor questions. So I really look forward to this case study today. So thank you to Lindsay and Angela from Sage Health Strategy, who worked really diligently with all the folks from One Hope United, who you'll meet today, to put this together. Lindsay and Angela are partners with ICOY and are really helping us, maximize the value of this Medicaid inquiry for the network members. So ask all the questions you have. Even if you're not sure you have a question, I would answer it and ask it and we can see if the answer is helpful to you. So with that, we're going to go ahead and get started, and I'm going to pass it over to Lindsay and Angela. Thanks, ladies.
Thank you so much, Jennifer. This is Lindsay. Good morning, everybody. Really glad to have you with us. And I really do want to echo what Jennifer said. There are no dumb questions. This is new to a lot of people. There's terminology that gets used and phrases that we might use. So please feel free to throw a question up in the chat box. We want to make this as interactive and useful as possible for the folks that are here to get the content. So thank you to One Hope United. They have just been great partners with us, and we're so willing to share and engaged in this process. So really excited to have them here with you. This is our agenda. We're going to turn it over to them in a sec so they can give you a little bit of a overview of their organization and the services they provide, to set the foundation for our conversation around their transition to Medicaid managed care. The way we've structured it is, if you think about the presentation we did a couple of weeks ago, we kind of laid out the process you need to go through, or that we recommend you go through in thinking through this transition. So what are those key questions that you need to talk about and answer for yourself as you go through this process? So we're going to talk about their transition, some of the questions that they asked and answered within their own organization about this, what they did and how prepared they were as an organization to make this shift. We're going to talk a little bit about the challenges and barriers that they encountered, both expected and unexpected, as well as some of the key lessons that they learned. And then we're going to wrap up with Medicaid successes, what worked, and really kind of reflect back on, was this a good decision? Are they glad they went through the transition? So with that, I will remind everyone this is being recorded and these slides will be shared. Jennifer and her team will make sure that anyone on the webinar today will get copies of these slides. So Antoine, with that, I'm going to turn it over to you. Antoine is the Chief Operating Officer of One Hope United. And Angela, I'm going to ask you to advance the slide because I can't seem to get my mouse to find the arrow that I need. Apologies, we're not Zoom experts, we're GoToWebinar experts. See, I keep doing that and I don't mean to. I apologize. Let me do it this way. There we go, Antoine, I apologize for that blip there.
No, no need to apologize. We're still all trying to figure out how to become experts in this virtual world.
Yes, there we go. All right, I think we are good to go.
Well, thank you. Good morning, everyone. Thanks to ICOY and Angela and Lindsay from SAGE for thinking of One Hope United and inviting us to be a part of this important conversation. As mentioned, I'm Antoine Trapeau, Chief Operating Officer here at One Hope United, and I am joined by several of One Hope United team members, including our Chief Financial Officer, Chris Nordlow, and our Executive Director of Residential and Day Treatment Services, Melissa Webster, and Kathy Benefield, our billing specialist in our community-based family services, along with other members that are probably listening in and here to support. I think this is a great process to the strategy to expand providers within the managed care world. As we know that several years ago, there were, a budget impasse that really impacted a number of community-based providers. And here's a time where we really need more, and probably in this year we've learned we really need these services. And so I'm very excited about additional providers joining the communities to help provide the services that are needed. So what I plan to do is just give an overview of One Hope United, and then I'm going to allow our experts, particularly Melissa and Kathy, really speak to the work that we do around Medicaid billable services, and go from there. So we can go to the next slide. So One Hope United is a multi-state organization. We provide a vast array of services in 4 states currently. That includes Illinois, of course, Missouri, primarily in St. Louis, Missouri, and in Wisconsin, in and around the Kenosha area, and then as well as Florida. Within those 4 states, we have 4 lines, well, not within the 4 states, but within the organization, we have 4 lines of services that provide a variety of services throughout those 4 states. And our 4 lines of service includes community-based family services, early learning childhood development services, and residential day treatment. And then our state of Florida kind of operates as its own line of services. You can go to the next slide. So our community-based services are primarily in Illinois that focus on behavioral health, family support, and youth services. In the state of Florida, we also do very similar services as we do here in Illinois, and I'll touch on that in a second. Throughout our lines of service, we serve approximately very close to, if not over, about 10,000 children and families. A good bulk of our work with behavioral health, or a good bulk of our clients, and CBFS are through our foster care or intact programming. However, a significant amount of our Medicaid billable services are through our behavioral health services within our community-based family service line of service. And we have, as you can see, we have a variety of different behavioral health intervention program, prevention programs. And as I mentioned, we have foster care and intact and family support services, a number of different evidence-based programs that are related to the Family First initiative, particularly with MST, which is one of our strongest families evidence-based programs within this line of service. Again, in Florida, we primarily do foster care and family support services We just launched a residential program. I'll talk about that shortly. But Florida is also preparing to build up its Medicaid billable services for counseling programs as well. You can go to the next slide. Our early learning and childhood development line of service operates 9 early learning child daycare centers, if you will. And we specialize in early Head Start programming. There's not too many, or if there's not any Medicaid billing that we do through this line of service. However, we serve annually around 2,100 children throughout our early learning programs. And it's a significant line of service for the organization as well. You can go to the next slide. Our residential programming is another area within OHU where we do a significant amount of Medicaid billing. We have 4 different types of congregate care, transitional living type of campuses. We specialize in serving high-end youth between the ages of 12 and 20, whether that's in a intensive residential program for youth that have some severe emotional behavioral disorders. We have a campus in the middle of, well, I would say more so Southern Illinois in Centralia. And then we have a campus far north of Illinois in Lake County. And then we have a transitional living program in Waukegan, as well as a therapeutic day school that's also in the Lake County area. And then we just launched a residential program down in Florida, and particularly specifically in Broward County, Fort Lauderdale, to serve dually involved youth that are involved with the child welfare system as well as the juvenile justice system. And Melissa Webster, who you'll hear from shortly, is our executive director over our Illinois residential programming, and she'll be able to speak to the types of Medicaid billing services and how we do that within our residential programs. Next slide. So, that's a good segue into how we transition to the Medicaid managed care. And Angela, Lindsay, is this the time where I will introduce Melissa?
Yes, thank you so much, Antoine. Great overview of the organization, and the participants can see that, you don't have to have service lines that are all Medicaid billable. A lot of what One Hope United does is not Medicaid billable services. But I'm going to turn it over to Angela to talk with Melissa about the decision-making process they went through to move to managed care. So off to you, Angela. Oh, and I've done it again. I am so sorry, Angela.
No problem. Thank you. Good morning, everyone. My name is Angela Haggard. I'll be moderating the session here with Lindsay. So thank you again, Antoine, for that great overview. We're going to transition now into the part of the webinar where we're going to do a Q&A type session with the participants from One Hope United, and they're going to speak to their experiences and things that they went through as they transitioned. Again, if you have questions, additional questions, please put those in the chat. Lindsay and I will be monitoring that. In addition to facilitating the Q&A with the One Hope United team. So we know that making the decision to move to Medicaid is one that needs to be thoughtful and thorough, which we talked about in our last session. And there are obviously pros and cons to that decision. We'd like to have Melissa talk to you about what One Hope United did and how they walk you through their decision and their approach to making this very critical decision for their organization. So Melissa, would you like to introduce yourself and help us answer this question for One Hope?
Absolutely. Good morning, everyone. I am Melissa Webster. I'm our executive director over our residential programs, but I'm uniquely a person to talk about this because I have a 22-year history with One Hope United. So whereas in residential, through my entire career, we've done Medicaid billing under the residential umbrella. I watched the process of how our community-based programs made the decision to go into Medicaid billing. The bottom line was, if we wanted to reach clients and continue to be viable, we felt as if we really had to dive into Medicaid. It allowed us to expand our outpatient services. Pre-Medicaid, we, for instance, would have youth in foster care that we would provide counseling to with no reimbursement, or like so many other providers, we would put them on a waiting list to wait for a Medicaid eligible provider. And what we just determined was we could be more efficient and enrich our own continuum of care if we built our own continuum of care with Medicaid as a heart. And so we started with one office part-time with a half-time employee in it. It's grown to 2.5 staff in Southern Illinois. It allowed us to build our teams and to develop internal resources as opposed to using other outside providers. We can switch the slide. I'm sorry, I've leapt ahead of all of you onto that next slide. We did find that several of our providers were requesting that we be a Medicaid provider. It really just almost felt like all the signs were there and evident. It also became a steady revenue stream for us to be able to rely on. Okay, we can.
And Melissa, I'm so sorry. I was just, Jennifer, I'm not sure if you took over, but Angela and I no longer have control of the screen here.
I did not. Marla, can you jump in and move the slides, please?
I cannot do it either.
Well, that's super exciting.
Well, I'll tell you, I covered every single thing on the slide, so you're not missing anything.
No, Melissa.
One other factor I'd add to this list is that because in my programming we had been doing Medicaid billing for some time, I think there was less trepidation and fear for our community-based programs to dive in. We knew there'd be challenges, but we also had a little practice. And so I hope that some of our lessons learned can offer you some of that sense of security. And I think we're ready to move on to what One Hope United looked like prior to transitioning to Medicaid.
Yeah, and I would say there's,
Yes, and
there's some things in the chat box about that. So go ahead, Angela.
All right.
yeah, go right ahead, Melissa. Will, I think both of the questions in the chat box you're going to cover here with your
Yes.
information for the team on what you look like before. As we know, you kind of need to set that baseline as you get started in this process. So go right ahead, Melissa.
All right, and I also can see some areas that maybe some of our folks from One Hope can chime in on some of those questions as well. I'll move on to that next slide if you want to bump us one more down. One Hope United, prior to Medicaid, the vast majority of our clients in community-based services were Medicaid eligible. As you can see, we estimate about 90%. Obviously, all of our youth in foster care were also Medicaid eligible. We offered, prior to Medicaid, mobile crisis. We were a SaaS provider, outpatient counseling, foster care case management, and residential care. The services provided were Medicaid covered benefits, although at the prior to that, we were obviously not being reimbursed for those services through that venue. We had staff that were appropriately credentialed. One Hope United always put an emphasis on hiring the best staff, but as we all know, we're always limited by income. You know, if the more we can offer the best staff, the more likely we are to attract the strongest candidates and to also retain those strong candidates. So although we always did our best to have appropriately credentialed staff, Medicaid has certainly given us a vehicle to attract better staff and retain those staff. I think that's all on this one. Oh, go ahead.
Yeah, sorry, Melissa, I'm just seeing a question in the chat. How did you assess when you said that 90% of the clients you served were Medicaid eligible, meaning they either had a Medicaid card or they would be eligible to get one if they applied? How did you find that out?
I think that, and again, this falls under our community-based service, but I believe because of our relationships with our clients, whether it be in Intact, whether it be in other community-based programs, we just had an awareness they had the medical cards.
Got it.
The vast majority, part of it was based on income level. You know, we knew the demographic we were serving were those folks that would be eligible based on their income or lack of income, and also just through incidental reports.
Yeah, and I'll just say in CBFS, our community-based services, most of our client base is in some shape, form, or fashion involved with the Department of Children and Family Services or the Department of Human Services, and they're with that alone, they're automatically eligible for Medicaid.
Absolutely.
Mhm.
Terrific.
that's
Okay.
good.
Thank you.
Melissa, I'm going to forward you to the next slide, okay?
Okay, perfect.
There you go. We have some questions in the chat about philanthropy and grant funding. So if either you or someone from your team wants to chime in about that for the participant, that would be great.
Yeah, I see those two questions. I think those would be good questions if that Chris, our CFO, could probably chime in on how we separate the grant funding from our Medicaid revenue, and then what our revenue sources.
I was hoping you'd say that.
Yeah, hey, it's yep, this is Chris Nordlow here. Let me take that the grant funding, the separation of funding question first. And for us at OHU, it really, we use two mechanisms. The first is that we have within our accounting system a whole separate series of line items, accounts dedicated to Medicaid. So even inside of, say, our residential program, all of that Medicaid funding that we receive gets booked to a specific line so that we can keep it separate and manage it and track it. The second is that there are some of the programs inside of our community-based family services that are of sort of scale. We actually just separate them into their own programs. So you can kind of imagine sort of the account level at the horizontal, kind of a horizontal basis, but then we also have kind of at the verticals, we'll separate them into their own programs so that we can manage them more cleanly and keep them separated. And then I think the revenue sources, before we move to Medicaid, that actually looks like it's the very first bullet point right on this slide. Melissa, do you want to talk to this one or do you want me to talk to it?
Chris, you go ahead.
Absolutely, yeah. So, yeah, I mean, I think there's, you know, a lot of the funding that we historically received for, you know, what has turned into Medicaid was historically funded by DCFS and DHS. You know, really, you know, if you think about the residential programs, there was some carve outs a few years ago that they historically had just funded through DCFS, eventually moving those over to HFS. We have historically gotten some community funding, so some foundation dollars. We actually still do get some foundation dollars that support this kind of work. So it was kind of a mixed bag of things, but principally it was government funding that has kind of been repurposed over into Medicaid.
Thanks, Chris. I think that I would also add that I think I mentioned this, but it's important. I think that we were receiving some pressure from external funders to leverage Medicaid funds. They liked what we were doing and they wanted to see us grow and they wanted us to have the availability to serve more clients, and they felt like Medicaid would be a vehicle for that. I am going to now punt to talk about the billing issues. Kathy Benefiel is one of our billing specialists and very knowledgeable about this. In fact, I think that she's going to have a lot of great information for you. So Kathy, I'm going to let you go next.
Kathy, you might be muted.
There, can you hear me now?
Yep, we got you now.
I am the billing specialist for the Southern region of One Hope United. The billing system that we use right now and the client documentation is SDS, which is Service Documentation System. What that helps us with is all of the staff and the clinicians can put in their notes, which is required for us to do. We then can transfer those notes over into an EDI file, and I upload that to a clearinghouse that we use in order to bill, which automatically downloads to all the MCO carriers. I do download into HFS Medi system separately from the clearinghouse that we use. I will say that it does work well because it's swift and easy to do. I can follow up to make sure that all the billing has went through, all notes are correct. It has a good system in for me to follow up in case there's a note that is unbillable for some reason that can get corrected before I bill. It has a lot of reports that are able to be pulled to help me access the billing. As far as the billing expertise, that came with me when we transitioned over to the MCO carriers a few years ago. It was a very learning process for me. I read a lot of manuals. I got in touch with a lot of my reps, did a lot of research. And you definitely have to be persistent if you're not understanding what's going on, or getting a hold of your provider rep is absolutely the way to go. And now that information, once you're credentialed, or even if you are billing out of network and don't have a contract yet, you are able to get a hold of a representative to walk you through that process and help you learn the procedures for each one of the MCO carriers.
Thanks, Kathy. And I think it
Hey, Kathy.
Go ahead.
I was just going to ask you a follow-up question, Kathy. With the billing system, was that technology that you already had within One Hope, or was that something that needed to be implemented once you decided to make the transition to Medicaid?
No, we had SDS already. We were already using that.
Okay.
Not for sure how long we've had that. Melissa might be able to help you with that. They have this when I came on board several years ago.
Okay, great. So that was technology you already had that you were able to pivot to use for the Medicaid billing process. Is that correct, Melissa?
Yes, we
Okay.
we had implemented One Hope prior to SDS had our own client management system that our IT department had built from the ground up. And, you know, there were strengths and weaknesses with that. But when we did our homework and decided and landed on SDS, and many of my peers in my line of service use SDS. One of the primary factors was the availability for it to be used for billing for Medicaid. And so as our community-based programs moved deeper and deeper into Medicaid billing, it was already in place there.
Okay, great. That's super helpful.
This is Lindsay. Just one other follow-up question for Melissa or Kathy. So when you made the decision to move over, excuse me, to bill for Medicaid, you didn't hire like a Medicaid biller. You really looked in-house, and Kathy, it sounds like you did a lot of work just on your own to get up to speed on, you know, how to submit the claims and how to, you know, follow up, et cetera, et cetera.
Yes, we did not hire. We went internally.
Mm-hmm.
We have been billing Medicaid actually in the southern region for several years, but we just billed through HFS and not the MCO carriers till that was implemented and brought out a few years ago. But we were just internal billing. We did not hire an outside source.
Perfect. Thank you. Angela, do you want to move us to the next slide? Actually, before we do that, are there any questions from the participants? Did we answer the ones that you asked? Jennifer, are you seeing anything? I'm not seeing anything, but I don't trust my Zoom skills either, obviously. All right, why don't we move forward then, Angela?
Yes, we'll go ahead and move on. I did check the chat, Lindsay. I think we've addressed the questions asked so far. So we're going to now hear a little bit more from Kathy on the contracting process that One Hope United went through and some tips related to that.
Okay. I wasn't initially involved in a lot of the contracting, but then after we were in the process of contracting with Blue Cross Blue Shield, Molina, Illini, Meridian, and now Youth and Care, which just took effect in September 1st of this year, I got more involved with that. One thing you need to do is be very persistent. You can bill out of network if you choose to. It is better, in my opinion, and what OHU decided was to be in network, because you do get a little bit larger amount of money if you are in network. You need to be persistent with your reps, keep in close contact with them. Even if you're out of network or in network, you are able to be assigned a rep. Those representatives are extremely helpful in helping assist with claims or any type of special billing projects. So you do definitely need to build some good relationships. I contacted them immediately as soon as we were going through this transition into the MCO carriers, so I could start building a good relationship with them. Definitely you would need to be able to get in and review all of these MCO carriers manuals. They're very helpful on what type of documentation you need, what prior authorizations you need. There's a lot of numbers, phone numbers in these manuals of contacts for contracting, conditioning, representatives, provider services. So they are very helpful. They do help you in the billing process. There are certain sections that pertain only to billing for these particular MCO carriers. So using the portals, it is actually very helpful and a key to your success.
You want to talk a little bit about, Kathy, about what you do on the portals? How are you using the portals?
I will use the portals once I have billed. I use the portals to get on there to follow up on claims. You know, if I have a claim I feel like I've been paid for and have not, I can pull up that client. I can pull up all claim information to see if they paid me, if they denied the claim, where I'm at on that, if they're executing the claim and just have not done it yet. You can check out eligibility for each client. Helpful, because a lot of times, like especially for the programs that I bill for, our children are in crisis or our adults in our crisis. They don't necessarily have their Medicaid card on them at that time. Now, this is just for me with my particular billing. So they might be able to say, well, okay, I have Molina. So I check eligibility on the Medi system, the HFS Medi system. And then I also can go in and check on each web portal to see if that client actually does have availability at the time that we are servicing them, and what their availability is a month from now, 2 months from now. So it's very helpful as far as that goes, and dealing with the claims to see where they're at in the process of paying us.
Perfect. Thank you. We have a question from Heather saying, we want to find out what coverage our current client base has. Would we ask about these MCOs? I'm sorry, I'm not sure I understand. I understand the first part, trying to find out what coverage your client base has. Are you saying, should we ask the MCOs directly? What would we ask about these MCOs?
Can you hear me?
Yes, yeah.
Yeah, I just unmuted. Yeah, so what I want to do is survey my current client base. Would I say, you know, which of these coverages do you have using the MCOs that are listed on the slide there? Or do I ask about specific plans? Or so in other words, if I ask, what is information is the client going to have? Are they going to know, for example, oh, mine's Blue Cross Blue Shield, or mine's Molina, or I just want to know how to ask the question so that the client knows what I'm talking about.
Well, in my experience on that, you can ask the client and ask them to see their Medicaid card. They should know their coverages. They don't always, as far as my experience has been with these clients. But once you are contracted, if it is an existing client and say you're contracted with Molina, you would be able to get on their web portal and pull up their Medicaid ID number, and you would be able to see their eligibility date, and what coverages they have.
I think we're trying to figure out beforehand which MCOs we want to contract with. So we're trying to assess which ones cover the clients that we're seeing, if that makes sense. It's primarily outpatient counseling, so.
I would say, depending on what area you are in, we have found with our clients over the last couple of years since the transition to the MCOs that we are contracted with the 5 that are listed here. That is most of the time who they have are these 5. So, and there again, it depends on what area you're in, because I know with Florida are starting to do the Medicaid billing, and I've been assisting with that a little bit. They are contracting with a few different MCO carriers, but they're in a different state. So,
yeah. So Heather, there's 4 statewide health plans, which you're seeing on your screen right now, and these are the 4 that One Hope United is contracted with. There's one additional health plan, and I don't know where you're located, that's in the state of Illinois, and that's County Care, but
Yeah.
that's specific to Cook County.
Yeah, we're in.
You're in Cook County?
So if
Yeah.
we're in Cook County, we should just assume that we should go ahead and contract with those 5.
Yes. Yes. They all serve Cook County. So they'll all have, now whether it's specific, I don't know your current, your client base, but as Kathy mentioned, the members or your clients will have they all get an ID card from their health plan. So they should be able to present that to you and show you their coverage.
Right, gotcha.
If you're trying to gather that before you're contracted, they would, we've worked with other clients in the transition, and they start collecting that information early on for just the same reasons that you're asking. They just want to have some sense of, what kind of coverage do the clients have that we're currently surveying. So I think it's an appropriate intake question to begin asking for sure.
Perfect. Thank you so much.
Yeah. We also have one other question. It's from Anne. And she's asking about the time commitment. Anne, can you take yourself off mute? Are you asking, Kathy's a billing specialist for One Hope United. Are you asking how much time she has or how much time the transition took? Could you just clarify your question for the group, please?
Yeah, I'm talking about this, about getting the contracts, getting impaneled with these different MCOs, how long it takes to do that. And it doesn't necessarily, I'm not necessarily assuming that she personally did it, but somebody on her team did it, and how much time that took and how long it took to do that process. Does that make sense?
Yeah. Yeah, I don't know, Melissa, it sounds like you are the historian. I'm not sure if you have any
Sure.
information to share with Anne.
Yeah, if Kathy and Chris also feel free to chime in. What I would say is, if you didn't get it from some of my statements before, One Hope United we're very grassroots. Like I said, we developed our own client management system for better or worse. In the end, it was for worse. We moved to SDS. But I would say that Kathy could tell you more about how billing evolved. I've watched billing in our community-based programs grow in terms of the need for staff, but obviously we wouldn't be growing our staff if we weren't being able to increase our billing, in large part because of Medicaid. Kathy can tell you, the good, the bad, and the ugly about how she developed her systems and how she developed her relationships with these funders to make billing more efficient. She's not the only person who does this. She does it for one of our regions. But Chris, I don't know if you'd add anything to that.
So maybe I would just add, Chris, who facilitated the contract negotiations or contract work with the MCOs?
Yeah,
Maybe
I mean,
that would help with Ann's question.
Sure. Yeah, and well, I'll kind of reference back to Melissa's framing of grassroots. So a fair amount of this really happened inside the program. So our program leadership took point on it. Kind of what we called shared services. The executive administration would get involved, but a lot of it was driven at the program level, which ultimately I'm certainly concerned and want to make sure that I's are dotted and T's crossed, but we also have to make sure that there's really sort of the right programmatic purpose to the contract, and that there's a kind of a clear understanding at the program level about what are we trying to get out of this contract, and does that contract actually provide that for them.
I would add the last point on this slide that's up. The woman, one of our primary leaders in our community-based programs, Bree, wanted to make sure the point was made. Organizational leadership is pretty close to the ground at One Hope, and so there was a lot of support, whereas certainly folks deep in the program, as Chris mentioned, were doing some of the legwork to get us ready to have these contracts. There was a lot of support at our chief level to do this work. And so I feel I think really Kathy's the best person to tell you about the percentage over time, and like over time, how much time she had to invest in it and what percentage. But it was truly a team effort. I guess I would start with that. But Kathy, how much time would you say it took to build some of these relationships and to develop the ability to bill successfully with some of these groups?
And I would say, Kathy, you may want to talk about the recent partnership with Youth Care, since that I think you're involved with that connection and transitioning those kids over. Like, what did it take, and how much time did it take in investment of making sure we were on board and ready and prepared, and as we work through the department in HFS with that process in Youth Care?
Okay, I would say that it took probably 50 to 75% of my time once we started the contracting process. I did and was able to go ahead and bill out of network, as I stated, when this all rolled out with the MCO carriers. So we were still getting paid, but it probably, I would say, took 2 months for us to get in network, even though we were still getting revenue being out of network. Worked a lot with my representatives, making the contacts, reading the manuals, but it definitely took 50 to 75% of my time. Then, of course, the other 50 to 75 or 50 to 20% was billing what I already had as an out of network provider till we were contracted. Youth Care Health and Choice, actually the DCFS wards, this was billed through Illini, then Meridian. They kind of merged on this, and then as of September 1st of this year, it became Youth Care Health Choice. This just came out September 1st, so we are still trying to get set up with them because we were already contracted, or my facilities and that I bill for were contracted with Illini and Meridian both. Our transition just automatically went over with Youth Care. Now I know, and Brooke, you might tell some of the difficulties or what is going on with you, because I know with the residential program, they were not on the contract as of yet with Youth Care. So I'm not for sure what kind of difficulties she might be having at this time. There are going to be some glitches because this is a whole new program and a whole new transition. So I have found in the past that sometimes it takes a month or two to get out of those little glitches, but it's not really anything that you can't handle. You just have to stay on top of it and keep involved in and do your research and be in contact with your representatives on a constant basis.
And the other thing that we always recommend for providers is really make sure you're documenting everything. Save all those emails, make sure you have the right contact information. Have that paper trail, because there is turnover in staff at the MCOs, just like there's probably turnover in staff at your own organizations. So having that paper trail and that documentation is really important.
Absolutely. I have a folder created with just emails from previous reps or this rep or that rep, so when the rep changes, I can say, well, I spoke to so-and-so before, here's the email, this is how
Right.
they send it to me, just so I have confirmation of our conversations, and if there's any difficulty in getting something processed or a procedure, I have definite documentation of what I've been told before.
Right. Okay, I'm just looking at the clock here. We're gonna move on. Keep those questions coming. We're now going to pivot and really talk about organizational preparedness. You may recall from our previous conversation that becoming a Medicaid certified provider is more than just submitting a bill. It impacts a lot of other areas of your organization. So, Kathy, we're going to move on to some of the things that you had to change or think about as you moved into billing for Medicaid. And so we'll put the slide up to remind folks. You may remember this arrow from our previous presentation. You can see the submit bill there towards the right-hand side, but there's a lot that has to go on before that bill gets submitted to the plan. So Kathy, I'm going to let you take it away here as well.
Okay, and I do want to apologize. I guess I'm cutting out really bad. I've had some computer problems for a couple of weeks now, so I apologize if you're not able to hear me very well. One thing for sure is the billing system is essential. Like we stated before, we have SDS, which is helpful with our billing and client documentation system, which you would need because you will have to upload all of your information and documentation when you do your billing. Once we went to the MCO providers, we contracted with a clearinghouse because before we were just billing Medicaid through the HFS Medi system, and I could upload my EDI files there. So a clearinghouse, in my opinion, is extremely helpful. We use Office Ally. There's a lot available out there. The MCO payers can tell you which ones they use. And I will tell you from my experience, the list that the MCO carriers have sent me when this originally came out, they didn't have Office Ally listed, but they do let us use them. So don't be alarmed if they come back and say, hey, we don't use that, because a lot of them they will go ahead and let you use. You can bill directly through some of these MCO carriers by going into their web portal. Once you're contracted, you'll get a login and you can do billing through there. I have found that using a clearinghouse is much easier and quicker for me to do the billing and get that uploaded. You also need to be careful and try to get a billing system, because once you bill, you'll start be getting your EOBs from these companies, and you'll need to do your reconciliation on that. And it's crucial to be able to reconcile, know that you're getting the amount of money you should be getting for services billed. Also to be able to help with any claim denials, why the claims have denied. It helps to keep track of that, absolutely. So you make sure that you are getting the money that you should be getting. Your claim or reconciliation process is the same way. You need to follow up, check your EOBs and your money that you're getting received. having a good essential billing system is helpful with that, which our SDS system and our clearinghouse also does. You can also use the web portal to follow up on claims that have been denied or paid, which I think I had stated earlier. It's very important to fight claim denials, because I've had a few issues where maybe the companies would deny a claim. I would follow up on that and I would fight the claim, and then I ended up getting my money. So I had to have documentation to fight the claim, which there again, the SDS system is very good because I had all my notes in there from staff, what I billed. So there was a lot of times that I have been able to get the claim denial reversed and get my money. As far as the intake process for the Medi system, each company has a different process that they use. So that is something that where you would have to read your manuals and be in close contact with your representative. The clinical documentation and training that's necessary, that is something probably Melissa could explain a little bit better. And also the implementation of the CQI, we have set up policies and procedures. I'll let Melissa touch base a little bit on that because she knows a little bit more about that than what I do. To develop a process as far as getting credentialed, that is something you will have to do once a year. The initial process, you'll have to do that in order to get contracted with the MCO carriers, but once a year they require you sending in a roster for your credentialing to keep it all up to date, which would have your staff NPI numbers, all of your facility locations, what your programs are, what you do, are you up to code with the state requirements as far as the fire marshals, and all your contact information. So that is something you would have to do once a year even after you are credentialed and contracted. Melissa, from there, I'll let you take over the implementation of the CQI and the necessary.
Sure. Just quickly, again, One Hope always had a strong grassroots CQRI. We've always had strong quality. We've always taken a lot of pride in the quality of our work, but Medicaid does take that up a level. Medicaid requires us to look more thoroughly and to make certain that we're meeting Medicaid requirements that are often best practice requirements. And so it really went hand in glove with the work of our quality department already, but it certainly required them to do some refining. Also, our CQRI department has always been involved in peer reviews. The peer reviews, we made certain that those tools and the files and notes being reviewed were also making sure we were Medicaid compliant. They were, our CQRI department's instrumental in our recertifications with Medicaid. And also when we were in a post-payment review process, they were very helpful. And I think because our programs have such a good, strong relationship with our quality department, we've always had very strong reviews in Medicaid. And so billing, there hasn't been a lot of question about billing eligibility because we put such an emphasis on that quality.
That's terrific. We do have a question from Anne. Can you talk briefly about the documentation that clinical staff must do?
Sure.
Treatment plans, case reviews, who needs to sign off? What's required from a documentation perspective?
Kathy, I'll start on this, but if you want to bring the community-based, you can bring in anything I missed from the community-based. And Brooke, I know you're on here. If there's anything you want to add, feel free. In our residential programs, and I believe this is similar across most of our community-based programs as well, there's an initial assessment that's been streamlined to the Illinois Medicaid CANS. I don't know if anyone on the call is familiar with the CANS. That's an acronym, CANS, Child and Adolescent Need. Anyone help me with the S? And that is our standard document. It's relatively easy to complete. Historically with Medicaid, we were having lengthier and lengthier assessments. And this is a very concise document, but it's a strong document that is relatively easy to complete. There is some training required to do it. I think a year ago I went to a day-long training. Most of the training and certifications now online for the IMCANs. The IMCANs also serves as the treatment plan. In my programming, we're reviewing the CANs monthly, at minimum quarterly, but our best practice is monthly. We're attempting to serve youth for shorter and shorter time so we can get them to less restrictive placements. And so we do our best to make sure we're on track on a monthly basis with that IMCANs. Anyone in Medicaid designation, a mental health professional and up, can complete an IMCAN, so it doesn't have to be a master's level clinician. And in my programs, I have both. Obviously, anytime a master's level clinician can do that, they're our first choice, but our billing gears off the IMCAN. So if I get a youth, for instance, on a Saturday, an MHP may complete that, and then it is always reviewed by an LPHA. And an LPHA in Medicaid talk is a licensed practitioner in the healing arts. That can be a psychiatrist or a physician, but in our agency, it is an LCPC, a licensed clinical practical counselor, or an LCSW, a licensed clinical social worker. And for each of my sites, I make sure that we always have that that LPHA. I myself am an LPHA, and so I can authorize service based on that designation.
Melissa, I just wanted to say,
go ahead, Antoine.
The S is strength, so child adolescent needs and strengths, and
thank you.
That is like a staple clinical decision-making tool that's used in all states and all types of social service, human service jurisdictions.
You know, and when you talk to therapists, they're an opinionated bunch. Some of them love the CANs, others don't. But I will say, in contrast to assessments I've done over my career, it's a pretty concise and accurate assessment of, you know, the youth or individual that you're working with. Kathy, do you want to add anything to that documentation? Oh, service notes. Let me say that, Kathy, before I punt back to you. We do write service notes. Historically, those have been reviewed by an agency that's no longer going to do that work. DCFS is now going to do that work. So we are very focused on supervisors reviewing those notes to make sure that we're capturing the clinical moment with our clients. And truly, that's the primary service array that you're going to see in a Medicaid file. I don't think I've forgotten anything, Kathy or Brooke.
I don't believe so. The only thing I might add is for the MCO carriers, for the SAS program that I bill for, we have a mobile crisis response intake packet, and we have to send those in along with the notification for each company so that they are aware, so that they can follow up, their staff nurses can follow up with our team on the clinical care and the process of taking care of these clients. So that is important for this particular program. That depends on what program you are billing for, definitely.
Right.
Notes are, as Melissa said, very important because with our system, that is what we bill for. So it's important to have good documentation on that so that you don't have any claim denials or so you have some type of a backup, but those service notes is what we bill from.
Yeah, no, great point. And is that, did you want to pipe in? Did that answer your question?
Yeah, I just have a follow-up question. Do the service notes have to tie to a treatment plan goal?
Yes, as a rule they do. Any Medicaid reviewer is going to come in and look for that golden thread. I will say the way we've managed that, because obviously, for instance, in residential care, or let's say just dealing with adolescents in general, or any client, other issues can be explored, and other issues we include in the case note, but it's been a discipline for my clinicians to learn. You always have to come back to that golden thread of that treatment plan. So whereas, you know, I have adolescents that may want to come in and talk about relationship issues or some of their feelings about milieu staff. That's included, but we always make sure that we're including that component, the component of the treatment plan that's driving them through our treatment.
So, so it sounds like the infrastructure you built to do this is through your CQRI. Because what I've found in Indiana is that a lot of agencies crash and burn with this because they don't have the infrastructure to support the clinicians doing this documentation.
I would agree with what you just said. Our CQRI department was critical. And again, the blessing for us was I always work closely with that team. They've always been very integral in what we do, but we do have some economies of scale. As Antoine talked about our service array, we're a big organization. This still was a lift, but all the components of the lift were moving us toward best practice. So I think as an agency from the executive leadership and on the ground, it was easy to see the value because it was really just making us better, although there were challenges along the way.
Great. Thank you so much, Melissa and Kathy. You guys have been so transparent and helpful. I'll just let the attendees know this last bullet item around MPIs and roster. There's a whole online session called Getting Credentialed that we shared last time for you in the supplemental materials. So that would be if you have additional questions about the MPIs, the roster, and getting credentialed, that's a great tool for you to reference. All right, so we're gonna move on now to challenges and lessons learned. We've been sharing those throughout the presentation, but just to kind of summarize a few of those key items that One Hope United thought would be helpful for the group to know. We know sometimes what not to do is just as important as what to do. So I'm going to turn it over to Melissa, and she's going to go through some of the barriers and lessons learned that One Hope United has experienced through their journey. Melissa?
I do feel like this has been a very organic process. So in the interest of time, we have talked about some of these. Some of the challenges there was a commitment. Kathy's entire job shifted. I'm sure she would agree as we moved into this revenue stream. I would also add that we had to make some changes. We had to strengthen some of our, whereas we focused on credentialed staff, we had to make sure we had credentialed staff because you can't bill Medicaid without that critical credentialed staff. I want to wait on some of the successes to talk more about the medical model and staff changes, but it is a good point to bring up here that Medicaid is a medical model. So, if you have any partnerships with any medical professionals, or if there are, if you have a medical director, they're going to be very familiar with this way of thinking. We do have to have ongoing staff training, new staff training change, orientation change to make sure people were getting the essential elements so they could fall in line with Medicaid requirements. Again, the plan for internal and external audits, internally we already were on a review schedule. It was enhanced, but we were already on that schedule. But externally, people will come in and review your files and give you feedback. Sometimes that is a very helpful process. Sometimes we get through it. And I'm sure if you have any external auditors, you can all appreciate the meaning behind that statement. I can stop there in case there's any questions on those challenges. So moving on.
Not seeing, Melissa, any items in the chat right now.
Okay. So in terms of lessons learned, it was very helpful to collaborate with others working through the process. Our, my line of service in residential and our community-based services, Kathy and Brooke, who are two billing professionals, definitely are collaborating and talking with one another to assist us as we moved more into the managed care arena. I think we all still have a lot of unanswered questions. When I meet with Antoine, he'll ask me how it's going, and we're going to know a lot more now that September is behind us and we're getting ready to bill for October. Kathy made this point earlier, use the MCO provider portals. You have to accept change. Like so many other government agencies, the only constant is that things will change, the rules will change, expectations will change. I think this example is that we developed a billing specialist system to bill to bill not just our Medicaid, but all our funders. And it's grown to the point now we're adding a billing manager to our organization chart to manage that and to bring symmetry and to make sure there's consistency across that. This one's Kathy, the enroll in the HFS provider notice alerts. That's just going to keep you up on information all the time. It is a wave of information, not just this one, but everything coming from all these funders. And so it's just critical to stay up, because what I find is they're telling us everything. It's critical that you prioritize understanding and absorbing that information as quickly as possible. Kathy, would you add anything to that?
No, I absolutely agree. It is definitely important that you would get a connection with the HFS and sign up for provider notices. A good example, as we've got listed here, fee schedule change. You won't necessarily know all of that stuff. And HFS, I'm signed up to get any type of alert for community-based services. So I received an email that said, hey, we're going to pay you more money. Here's the change. So it's very crucial, because I have found that the MCO providers usually won't tell you that. But it is crucial to be on the MCO providers portals, because you can also sign up there for, most of them provide you with a monthly newsletter, and they'll send you an email stating, hey, we're going to have a webinar on this particular subject, or hey, this has changed just within our company. So most of the provider portals are just within the company and their changes, but they do send out a lot of notifications. But the one that I feel is most crucial is the HFS provider notices.
Great. Thank you, Kathy and Melissa. We're going to move now move on to successes. Lindsay, do you want to take it from here?
Sure. So the last thing we wanted to do was to scare y'all. It does seem like a lot of work and a lot of learning and coaching along the way. But we thought we would finish on a positive note and ask Melissa to share, after all this work and the barriers and the challenges, are you glad you made the transition? What are some of the successes that you feel going through this transition has meant for One Hope United as an agency, and more importantly, for the clients that you're serving?
Well, I think that probably, obviously, and Chris would echo this as our CFO, a stable, consistent revenue stream was, right out there, number one, as something that, as a leader, my staff's jobs are more secure when I have a stable revenue stream. Medicaid definitely took up the professionalism of my staff and services. I've been a clinician for nearly 30 years, and I worked in a community mental health center that billed Medicaid. And as I moved into residential, there were challenges with meeting deadlines for my team. Clinicians, as a rule, struggle with some of those issues and documentation issues. With Medicaid, there's no option. The documentation has to be done well, it has to be done up to standard, and it has to be done on time. And that's been a big shift for the programs I've supervised, and I think that CPFS leadership would probably agree with that. It's allowed us to expand and provide new services, to have new billing opportunities, but more importantly, to serve more people. One Hope at our root, our goal is always to serve the people who need us the most and to offer them the most opportunities. And with Medicaid, we've been able to offer more services. We've been able to expand the number of people we employ. As a leader, that's always critically important to me, more of the best folks to serve people. It also allows us to offer services to a broader client base. I said, from the beginning, 90% of our clients were Medicaid eligible, but we're not just offering services to those folks, we're offering services to other people who are Medicaid eligible now. I'll give you one example I shared with this team as we prepared this. In my residential program, because Medicaid's a medical model, I was able to add to my nursing staff. I always had one part-time nurse. Now I have 2.5 nurses, 2 full-time and a part-time nurse. Because when we administer medication, it used to be a youth care worker that maybe had a high school diploma or a GED giving youth medicine to self-administer. Now a nurse oversees that process. A nurse actually puts the medication in a youth's hand. We're able to do blood draws on, at our residential campus. We're able to give, for instance, Haldol shots to youth suffering with thought disorders. And the story I shared is because I have a richer nursing milieu, they don't just administer meds, they keep an eye on my kids. So I had a youth with a stomach ache that, God forbid, my milieu staff might have missed, but because the nurse was there, she knew what to look for. The child had appendicitis. And so Medicaid has given us many gifts in addition to just that increased revenue stream.
Melissa, that's just a wonderful summation. I think I always like to bring it back to the clients that we're serving. And that just gives me goosebumps, because we're all in this because we want to see, high quality, accessible services for folks that are often marginalized or underserved. So thank you for that wonderful summation. At this point, we're just going to open it up and see if folks have other questions or comments for our One Hope United team. What other things did you want to ask? Did you want to do a deeper dive in? Did we not cover that you would like us to kind of mention?
Yeah, it's Heather Melnick again. We serve primarily a low-income population, and all of our services are available on sliding scale. And in the past, we've, especially when healthcare coverage for all came into being, we kind of wondered what would happen since people are generally paying on sliding scale. What we found is we had at the time several clients that told us, well, I have Medicaid, but I can't afford my deductible because it's too high, and so I'd prefer to remain on sliding scale. So I guess I'm wondering if you experience that, and if so, how do you help folks with being able to do that? Is there a way to help them offset the cost of their deductible? Like, could we use another funding source, or
Yeah.
would it be like insurance fraud if we're paying the deductible, or how do you work with that?
So this is Lindsay, and I'm going to jump in. There are no copays or deductibles with Medicaid. It is a cost-free program for the Medicaid recipient. So I'm not sure if that particular client thought he had Medicaid, but in fact was on an exchange plan, or was not fully conversant in the Medicaid benefit. But if you have a Medicaid card and are covered, you do not have any copays or deductibles.
Okay. Yeah,
and to add to that, providers cannot balance bill members either. So again, it's a cost-free program.
Okay, thank you.
Yeah.
Angela, can you explain? Sorry, this is Jennifer. Can you explain what you mean by balanced bill numbers?
So many times providers may, you'll have like a charge master. So what you're, and Kathy can probably more eloquently speak to this, but billed charges, you're not going, with the Medicaid program, in most instances, you're not going to get paid your full billed charges. But that isn't anything. With a commercial plan, you can sometimes, as you might recall from your own insurance, you could receive a bill then that you would pay the difference. With Medicaid, the provider accepts the Medicaid payment, and there's no further billing process that happens with the member.
And yes, I will say that HFS puts out a fee schedule, which we recently just got an updated one effective July 1st. On those are all services available, and it tells you exactly what you will get paid for those services. So, like she said, you will not get paid anything other than what is on that fee schedule.
Thanks, Kathy. Are there any other questions that the team can answer for the attendees today? I'm not seeing anything in the chat. So I think, is there any additional parting comments that One Hope United wants to give the group before we sign off?
This is Anton. I'll just say, thank everyone for the questions, and I just want to thank my team for participating and being available to really help out the community in this way. And of course, we're open as an agency if there's any other way that we can provide some additional clarity or questions or assistance or even partnerships. If they align right, we were open to having those conversations.
Thank you.
Thanks so much, Antoine. Yes, we would just echo, thank you, One Hope United. You kind of got a call in the blue, and we appreciate you all just picking right in, engaging right away with the team here to give a product that can be useful for the community in transition. So thank you very much to you and your team. Jennifer?
Thanks. I want to thank everyone for joining us today, and I especially want to thank Lindsay and Angela and the entire One Hope United team for all of your help in putting this together. I would encourage any member of the network who's here or watching the recording, as questions come up, as scenarios come up, as you're wondering like, well, we think we want to move forward, what are the next couple steps here? Reach out and let us know what you're in need of. So that we can connect you to some expert resources, because it's a very doable process to become Medicaid eligible, but it's certainly not simple, and there's no reason you should have to struggle through it by yourself. So I would, I'm a great person for like tomorrow morning, I'll wake up and have like 4 questions on my brain that I didn't know were there today. So, feel free to send those to the network email or to myself, and we'll get those put together in some FAQs for you, because this is, of course, an ongoing conversation. And just a reminder to our network members that we will be putting together some learning collaboratives. So for those of you who aren't sure yet if you're going to pursue Medicaid eligibility, we'll have a learning collaborative to continue to dig in on those questions. And for those of you who think you're going to move forward, we will also have a learning collaborative to support you in that process. So as you come to a decision point about which pot you think you're going to be in, and if there's anyone on here who is already Medicaid eligible but is trying to, optimize the use of the system, that will be our 3rd learning collaborative relative to Medicaid. So the more questions you send us, the better we can focus those efforts to support you. I think for today, I don't see anything else in the chat. So I'm gonna say that we are done. Happy Friday. I hope everyone has a lovely weekend and gets some rest and some restoration to your soul. And thank you again to Angela and Lindsay and One Hope United.